right, good evening, everyone. My name is Ryan Spiker. Thank you for joining us. We are excited to continue the AO Spine North America Fellows webinar series. And so tonight we are excited to talk about high-grade lumbar spondylolisthesis. And so really an exciting topic. It's a topic that kind of bridges that gap between degenerative and deformity surgery. Some interesting concepts we'll cover, and excited to be a part of it. Again, I'm Ryan Spiker. I'm here at the University of Utah. I'm joined by Dr. Nicholas Spina, Dr. Sri Nandiala, and Dr. Justin Stoll, all here at the University of Utah. So a few disclosures. I do some medical education with Stryker, no other financial relationships for the group for tonight. Certainly the AO North America has to acknowledge its funding that comes from Synthes, and we certainly appreciate that. It does not impact what we have to say tonight. Again, AO North America is an independent nonprofit subspecialty society dedicated to improving care, and we're not endorsing or promoting the use of any specific product or service this evening. Just hoping to teach you guys with the intent of enhancing your kind of learning experience with some of the instrumentation. So for tonight, your microphones have been muted, your videos have been turned off. We do have an active Q&A that we will all be monitoring, so please send in your questions through the Q&A. We'll be taking breaks every 20 minutes or maybe even more often to go through some of those questions. We'll also be answering them by typing into the Q&A with you. The chat function is just for faculty. So the Q&A, again, is your opportunity to interact. We also have some questions for you today, so please participate in those audio response questions. I think it helps make it a little bit more entertaining for all of us to kind of see where people are and how people are thinking about things. So for today, our goal is to describe the biomechanics of high-grade isthmic spondylolisthesis and how pelvic parameters can impact the treatment of this entity. We want to talk and identify the risks and benefits of different surgical techniques on the outcomes in high-grade spondylolisthesis, and then also appreciate some of the controversies, including one of the more common ones, which is the controversy in selecting the upper and lower instrumented levels when you're doing these cases. And so keep those objectives in mind, and we certainly will be too as we're going through our talk. I obviously am doing the welcome here. I will pass it off to Justin Stoll, and then Nick Spina will give us a case discussion with some Q&A response, and then Sri will take us home with some clinical outcomes. And then we have a few other cases to go through if we have time, but we certainly will be mindful of the time and try and finish in 1 hour. All right, so again, questions, please put them in the Q&A. I will start checking those now, and I will pass it off to the good Dr. Stoll.
Thanks, Dr. Spiker. Let me get my screen share set up here. And so I'll go ahead and get started here. So just starting off, my name's Justin Stoll. I'm one of the fellows here at the University of Utah. I'd just like to acknowledge Sri, my co-fellow, who will be presenting later this evening, as well as Dr. Spiker and Dr. Spina. Thank you all. They were all involved with helping with this talk. I'm going to get started off talking about the biomechanical considerations in high-grade isthmic spondylolisthesis. I'm going to talk a little bit about background. We'll talk about some common measurements for the evaluation and understanding of isthmic spondylolisthesis. And then I'll be talking about the local biomechanics of the lumbosacral junction and how that's affected by spondylolisthesis. Finally, I'll wrap up my talk discussing some operative reduction techniques and just sort of debating the pros and cons of some things that are utilized in the treatment of high-grade isthmic spondylolisthesis. Isthmic spondylolisthesis is a defect of the pars intra-articularis. Effectively, that is a dissociation between the anterior and posterior arch of the vertebrae. As you can see here with some clinical imaging at the L5 S1, the L5 pars, we have elongation and defects in the pars at that level. There we go. As mentioned, pars defect leading to separation of vertebral body from the posterior elements. Wiltse classified isthmic spondylolisthesis into 3 different categories. Type A being stress fractures, and type B being elongation. A and B are both issues of chronic, long-standing trauma, repetitive micro trauma at the pars, most commonly at L5. Type C is an acute or traumatic pars fracture. About 11% of isthmic spondylolisthesis fall into the category that we'll be discussing today, high grade, and we'll kind of go into that classification here shortly. In terms of the epidemiology of isthmic spondylolisthesis, this pathology has not been observed in newborns. However, by adulthood, the historic estimate is about 6% of adults are affected with isthmic spondylolisthesis. Again, that's historic literature. A more recent analysis as a branch of the Framingham Heart Study identified asymptomatic adults having an incidence of 11.5% with isthmic spondylolisthesis. So it's almost twice the amount is initially believed to be affected by this pathology. 2/3 of the patients, or 2/3 of the adults affected with this are male, and about 90% occur at the L5 pars with spondylolisthesis at L5S1. It should be noted that this is more common in folks that have repetitive hyperextension. Most commonly, that's athletes, wrestlers, rowers, football players, especially linemen, and gymnasts tend to have higher percentage of those affected with isthmic spondylolisthesis. The most common classification system is the Myerding classification. Myerding described this in the 1930s, actually in an OBGYN journal, and he divided the sacrum into 4 quadrants. The posterior aspect of the L5 vertebral body, as it listheses on the sacrum into these quadrants, is what describes the grades. So grade 3 and 4, or more than 50% slip, are what is to be considered high-grade isthmic spondylolisthesis, with grade 5 being 100% translation or spondyloptosis. So this focus really, this talk will mainly be focused on the grade 3, 4, and to an extent 5 isthmic spondylolistheses according to the Myerding classification. There's a little caveat that I wanted to mention here. In recent literature, the vertebral body hypoplasia as a factor to describe isthmic spondylolisthesis was noted. This group in 2011 published a study identifying just about 1/3 of patients evaluated with isthmic spondylolisthesis having some element of L5 vertebral body hypoplasia. Although the patients that they evaluated had other levels of isthmic spondylolisthesis, the only level that was noted to have vertebral body hypoplasia was L5. So what they proposed was, rather than classifying the listhesis based purely on the Myerding classification system, to take into account the ratio of the inferior end plate of L5 and the superior end plate of S1 when you're making this classification. Use that ratio to help guide the grade with which you're classifying these patients. So moving on, the measurements most commonly used when evaluating isthmic spondylolisthesis are the pelvic parameters, pelvic incidence, pelvic tilt, sacral slope, and lumbar lordosis. And as we all know, these are intimately involved measurements that have an effect on one another. I think this is a really nice slide. It shows some of the key elements that we were just briefly touching on. So sacral slope is really a proxy for orientation of the pelvis, and sacral slope is closely related to lumbar lordosis. So just keep that in the back of your mind. Pelvic tilt is really related to positional compensation in the sagittal plane. As the sagittal axis moves anteriorly, the pelvic tilt will increase in an effort to balance the spine with pelvic retroversion. This, interestingly enough, is really the only pelvic parameter that's been closely correlated to health-related quality of life outcome scores. Lastly, the pelvic incidence. The pelvic incidence, as we all know, is a fixed value that really expresses the interdependence of pelvic tilt and sacral slope. And so you can see here that the pelvic incidence is defined as pelvic tilt plus sacral slope. Again, pelvic incidence is a morphological parameter, which is not affected by patient position. This doesn't change after adulthood. This doesn't change. And so you can see as the pelvis retroverts, the pelvic incidence remains the same. The pelvic tilt, on the other hand, changes. As mentioned before, this is a compensatory mechanism as patients become, as the sagittal axis moves anterior, the pelvis will retrovert, increasing the pelvic tilt as a method of compensation to keep the spine over the body. And this here is increasing with changing patient position. So pelvic incidence and lumbar lordosis, as stated, closely related measurements. With small pelvic incidences, we notice a more vertically oriented spine. There's a horizontal sacrum and less lumbar lordosis. However, with large pelvic incidence, we see a more vertical sacrum and more lordosis. Essentially, the lumbar lordosis can be estimated to be pelvic incidence plus or minus 10 with normal alignment. So touching on some of the biomechanics, the sacrum is essentially a platform for the spine. Its orientation is a product of pelvic rotation, lumbar lordosis, hip extension, as we were alluding to on the previous slides. Forces at the lumbosacral junction are mostly compression and shear. And shear compensation is provided by the disc to a degree. However, that's better in compression. The paraspinal muscles helping with posture, and the posterior elements, most notably the facet joints. I think it's worth noting that with facet joints in more coronal alignment versus a more sagittal alignment, there's increased exerted stress on the pars and spondylosis. Also, with decreased intrafacet distances at L4 and L5, you can have impingement of the pars below at L5 essentially, which is the microtrauma that we were previously talking about that can lead to the defect in the first place. So what happens with isthmic spondylolisthesis? With isthmic spondylolisthesis, we lose the posterior restraint to shear forces. That there's a disconnect between the anterior portion of the spine and the posterior portion of the spine, like we noted with the pars defect. So the disc, which is better in compression, is asked to resist shear forces, which it's not really designed to do. With increased pelvic incidence, the number that's noted in the literature is 68.5 degrees. There's increased shear and increased risk of progression of spondylolisthesis. Increased pelvic incidence, pelvic tilt, sacral slope, and lumbar lordosis have all been correlated with an incidence of isthmic spondylolisthesis. The increased slip angle, which I'll show in a minute, is related to an increased risk of progression of spondylolisthesis. So here we can see the slip angle, and the slip angle is really a measure of local kyphosis. It's often compensated by patient hyperlordosis, which again increases the shear at the lumbosacral junction. And then the next image on the right-hand side shows lumbar index. Low lumbar index is vertebral body wedging essentially at the L5 vertebrae, and it's correlated with high-grade slips, but interestingly, it's not prognostic for progression of slips. So this study by Hresco et al. In 2007 broke down isthmic spondylolisthesis, high-grade isthmic spondylolisthesis, into those that were balanced, having a high sacral slope and low pelvic tilt, and unbalanced with low sacral slope and high pelvic tilt. As you can see in this illustration, with balanced pelvis on the left and unbalanced pelvis on the right, there are some notable features of an unbalanced spine. In the unbalanced pelvis, we see that there is more pelvic retroversion The lumbar lordosis is a slower arcing curve over more vertebral bodies. And in this clinical depiction, with A being a normal control, B being a balanced pelvis, and C being an unbalanced pelvis, there's some differences that I think are important to discuss as we're talking about the orientation, the spinal overall sagittal alignment of the spine as it's related to high-grade isthmic spondylolisthesis. So you can see in the balanced high-grade isthmic spondylolisthesis, the pelvic parameters closely resemble the asymptomatic controls. Whereas the unbalanced pelvis, the high-grade isthmic spondylolisthesis have increased kyphosis at the lumbosacral junction. As mentioned, the lumbar lordosis sweeps over many more segments. And there's a higher L5 incidence, which is similar to the pelvic incidence, but measured off of L5, obviously. Lastly, there's less thoracic kyphosis, which essentially is analogous to having an unbalanced spine in the sagittal axis. This was dubbed by the authors as a listhetic posture, which I thought was interesting and apt. And they posit that these patients would benefit from reduction of the spondylolisthesis to increase the compression, increase the compressive load, and decrease the shear forces at the lumbosacral junction. And so the key point here is really that reduction techniques may be more important in unbalanced patients with a retroverted pelvis in the setting of high-grade isthmic spondylolisthesis. So to round out this discussion, I'm going to talk about some operative considerations. I apologize, my polling question is not multiple choice, it's just kind of food for thought for the audience. And I was wondering for the audience, is there routine reduction done for high-grade isthmic spondylolisthesis regardless of balance? So something to keep in mind as we're going through this. So this was part of the series of controversies in spine. The question was, is reduction in fusion required for high-grade isthmic spondylolisthesis? One group of authors argued that no, reduction is not required for all high-grade isthmic spondylolisthesis. They cited evidence that equivalent patient outcomes were noted with or without reduction. If anterior column support is utilized, fusion rates are equivalent to those that are not reduced. Transsacral strut grafting without reduction does not show increased slip angle over time, and there's a lower risk of neurologic complications intraoperatively. All that being said, a lot of the literature that was cited for the argument against reduction was historic literature, a little bit more aged. On the other hand, some authors argued that yes, reduction should be used. Reduction in anterior column support increases fusion rate, improves spinopelvic balance, which goes back to the balanced, unbalanced pelvic discussion, and that improved patient-reported outcomes in the long term were associated with better pelvic balance. That being said, the paper didn't specifically recognize the balanced versus unbalanced pelvis as we've discussed. This study, however, did focus on that. This was an evaluation of normal pelvic balance in a reduction after high-grade isthmic spondylolisthesis. There were 60 patients, not quite half and half. 36 had balanced pelvises, which remained balanced with reduction, leading to improved quality of life outcomes. And the 24 who had unbalanced pelvis, almost half became balanced, and those two had improved quality of life outcomes. And so the conclusion is that surgical reduction is effective in maintaining and restoring normal pelvic balance post-operatively and associated with improved quality of life outcomes. So with regard to reduction technique, this is an oversimplification, obviously, but the idea is to create a lever to reduce the spine into a better anatomic position. And so we do this by getting solid screw fixation in the sacrum and or pelvis, then obtaining screw fixation above the segment to reduce. We can distract the L4 body from the sacrum and disengage L5 from S1. and then provide screw fixation and compression to keep things in place. My next polling question was with regard to the timing of interbodies. Does everybody do their interbody before to aid with the reduction, or are there folks out there that prefer to do the interbody after the reduction's been obtained? So operative reduction technique, as alluded to in the pros and cons of doing reduction, there's a risk of L5 nerve root injury with reduction. And so an interbody cage placed before or after reduction can help maintain the reduction and increase surface area for fusion. But if it's placed before, there's been some evidence to suggest that you can protect the L5 nerve root. Furthermore, it can provide partial reduction after its placement alone to aid with the final alignment of the construct. And so the last polling question I have, and again, I apologize, more food for thought type propositions. I was wondering if there's a preference for ALIF versus posterior based interbodies for high-grade ischemic spondylolisthesis. Focusing on anterior interbodies, this is biomechanical analysis that was recently published in the literature. Interestingly, it's a sawbones model, so it's not cadaver specimens, it's not human beings, but the biomechanics that they used were validated and showed that less torque was applied to achieve reduction. There was more angular correction. And furthermore, there was less force through adjacent disc spaces when achieving the reduction by doing an anterior approach as opposed to a posterior-based interbody reduction. A few more articles which really emphasize the benefit of anterior versus posterior interbody in different ways. The first study at the top showed that anterior interbodies had a better restoration of pelvic parameters, which we discussed, but showed no difference in clinical outcome scores. They studied VAS and ODI for this study. The next by Min et al. Showed that anterior interbodies had less adjacent segment disease at about 2 years of follow-up and had better short-term outcomes, patient-reported outcomes, and they used JOA. That, however, was short-lived. There's no difference in clinical outcomes greater than a year. And they noted no difference in pelvic parameters when evaluating the final construct radiographically. Lastly, this study from the Journal of Neurosurgery Spine in 2007 noted that anterior interbodies radiographically outperformed or had better outcomes rather than T-lifts. They noted increased foraminal height, better local disc angle, and increased lumbar lordosis as well. They also noted no clinical difference with regard to the outcomes, neither objective in terms of complication or pseudoarthroses or subjective outcomes, and they use VAS scale. So a couple other considerations for the reduction. If we're doing a reduction for high-grade ischemic spondylolisthesis, it's worth considering pelvic fixation. In a high shear environment, S1 screws can experience a high degree of strain. Iliac bolts or pelvic fixation can help protect those S1 screws and may be useful for high-grade ischemic spondylolisthesis. Essentially, the pelvic fixation can help accommodate for sacral screws that may not have a great quality bone or that are experiencing a high cantilever load based on the overall alignment of the spine. And lastly, I just wanted to touch on the Gaines procedure and modified Gaines procedure. Gaines introduced this technique, I guess, 40 years ago now. And the procedure for high-grade ischemic spondylolisthesis is an L5 vertebrectomy. The thinking, so it's a staged procedure. Interestingly, he staged over a couple days. So he would do the anterior portion first, and then put the patient on bed rest and log roll, and then do the posterior portion of the surgery a few days later. The technique that he utilized put people on bed rest for 4 to 6 weeks post-operatively. However, in the long term, his patients did well. Out of 30 cases in this follow-up study, 2 had permanent foot drop, but the vast majority of patients had alleviation of their symptoms, back pain, leg pain, or weakness. Although more than those 2 patients with foot drop, there were some fleeting neurologic symptoms, but those were all resolved by 6 months, except for the 2 that had longstanding foot drop. And then I thought it was worth noting that there's been a modified gains procedure for spondylolisthesis, which was published recently in the literature. And this is basically a partial vertebrectomy of L5. There was no outcome data that I noted in this paper, but I think that the take home from both of these really show a restoration of pelvic tilt and balance of the pelvis. So that was not the focus of either of these papers, but going back to one of the cruxes of the talk that I've given here, I think that that one of the notable features is that the alignment of the spine was changed dramatically with the gains and the modified gains procedure. So that's all I've got for today. I really appreciate all those who tuned in, and I'll turn it back over to Dr. Spina at this point.
Thanks, Justin, for that excellent talk. I'm going to try to share my screen here. While I'm pulling up the case, maybe we can just first address your 3 polling questions, or at least Dr. Spiker and I can sort of tell you what we think, even though you're training with us. But you know, your first one was about routine reduction for most high-grade isthmic spondies, regardless of balance. I would tell you my personal gestalt is I will try to reduce all of these as long as they're mobile. Especially in younger patients, I tend to think more about balance. And if I can't reduce it and it won't move, modifying my technique to gain lordosis through some other means, either taking the pedicles down to free up the L5 nerve root and doing a L5 PSO plus or minus inner body above at 4-5 versus not. You know, Dr. Spiker, how do you feel about, you know, trying for a reduction in most of these cases?
Yeah, I agree. I think, you know, this is really a problem that we see mainly in younger active patients, and often, you know, improving their pelvic parameters is really important for their long-term outcomes. And I agree. I really find that Horesco paper as a kind of landmark paper from 2007 that kind of describes the balanced versus the unbalanced, and those patients that have the high pelvic tilt and are really compensating for their deformity. If you lock them in that position, I don't think that you're doing them any favors. There's certainly some risk with reduction. There's risk of screw pullout. There's risk of nerve root palsy, but the upside has also been pretty well shown in the literature, especially in those unbalanced patients. And so I agree that in general, if I can reduce them, I certainly would try. And I think that there's pretty good data showing that long-term, when we improve sagittal parameters, we improve outcomes. And we can kind of take some of that deformity data and apply it in situations like this.
Yeah. I'd also like to remind everybody to use the Q&A box in the bottom of your screen to ask any questions to any of the presenters. I think your second polling question was inner body before or after reduction. Especially in these high-grade slips, there's often significant doming of L5 or doming of the sacrum that really makes putting an inner body in before any type of reduction very, very difficult. And so my standard practice is to do it after a reduction to try to recreate the disc space. But it's often a combination of the two. I will enter the disc space in an attempt to free it up without putting my inner body in during a sequential distraction and reduction maneuver. And I always skeletonize the 5 nerve roots sort of before doing any of that, and you're looking at the disc space anyways. So I won't put the final inner body in until I get a reduction, but I will enter the disc space sometimes to free things up and help with paddle shavers on both sides to sort of assist in the reduction. Dr. Spiker, similar, different?
Yeah, sorry, just unmuting there. Yeah, I agree. I think getting into the disc space is really critical for the reduction. I agree. I think you have to get into it. I like getting into it bilaterally. I think also just having a good reduction plan. I think sometimes people get into these cases, and certainly, as a fellow, I didn't always know what our plan was as I was starting these cases. And knowing exactly what you're going to do. Are you going to do this dome osteotomy of the sacrum? Are you going to put screws in 4 and then kind of slowly distract and then lever back the pedicle screws in 5 and kind of reduce it that way? Are you going to use an interbody cage and kind of open up both sides and then place a cage and then distract it over the cage? And having those discussions kind of with your mentors, I think, is critical to really get the most out of the cases you're doing and understand why in one setting they're doing one thing and another thing. But I agree. And I think with these big deformities, sometimes they need bigger surgeries. And so, I'm not shy about extending up to L4, extending down to the ilium for fixation in order to help me achieve the reduction that I think they need. Obviously, you try and do it as small as you can, but remembering that you can sometimes aid your reduction by getting more fixation, I think has been helpful to me. And you can even remove those screws. So sometimes putting in L4 screws, for me, can be really helpful to reduce that 5 body back. And I've done that a few times where I place screws in 4 just to help me with the reduction, and then ended up taking out those screws and just doing a 5-1 fusion. So remembering that placing screws doesn't mean you have to fuse the level. You can place them laterally away from the facet and not injure the facet and still not kind of have to buy that level. So I know we're cutting a little bit low on time, so yeah, may cut it off there. Again, I will start responding to some of these Q&A questions on the side. Please take a look at that, and I'll pass it off to Dr. Spina for a case.
So real quick, this is a 23-year-old, very active female. She's a softball player, plays pretty competitively after college. She comes in with severe low back pain and bilateral L5 per dick. I don't have the MRI cuts, but as you can imagine, she's open centrally and has, significant L5 foraminal stenosis causing her pain. And what you see here is her flexion extension films. I use flexion extension to get an idea of, is this mobile, will it move? I often compare it to the MRI. It looks pretty stuck, although there might be a slight reduction in the degree of kyphosis segmentally between flexion and extension. So, I thought this would be relatively mobile. After Justin's great talk about pelvic parameters, obtaining routine Scoli films in these high-grade spondies, I think is crucial. Understanding what their pelvic incidence is. You can see that this patient has an extremely high pelvic incidence of 80 degrees. High PIs have been associated with isthmic defects, secondary to shear stress across the disc space. When you look at her overall lumbar lordosis, she has about 72 degrees from 1 to 1. But when you look down at her low lumbar distribution or her lower lumbar lordosis, she really only has 8 degrees across 5-1. The other thing that I like to look at is where the lordosis stops. While her pelvic tilt is not extremely high and while her sacral slope is relatively maintained, you can see that she's carrying her lordosis kind of all the way up into her thoracolumbar spine, which young people can do. They still have the paraspinal musculature to maintain this. So to me, this is a patient with high-grade isthmic spondy, young person, definitely compensating for the loss of lumbar lordosis down low with a high pelvic incidence. And so when I'm thinking about treating this case, I'm trying to reduce this. I'm trying to get this patient in better alignment. I'm going to do a circumferential fusion, and I think Shri will touch on the outcomes, a different technique. So I won't belabor on that next. But and then thinking about where I'm going to stop, I tend to like to get screws past the center of rotation of the deformity. So for me, ending a screw at the tip of S1, if L5 stays there, there's a lot of pull out and a lot of stress on that construct if L5 doesn't reduce. If L5 is pretty mobile in a young person with good bone, I feel pretty comfortable stopping at S1. And then due to her high grade slip and L4 being relatively neutral to the floor, I decided to go to L4 on this. And so here you can see that she has 8 degrees of lordosis across 5-1. following 4-to-1 fusion with TLIF, you can see we obtained a really, really nice reduction at L5S1, which was aided by going to 4 and getting an inner body in to restore lumbar lordosis. So, for me, this talks a lot about what Dr. Stahl just talked about, trying to restore that lower lumbar lordosis, get her better balanced, and aid in restoring more of a natural curve to the spine, hopefully for longer term, 40, 50 years down the road, achieving better balance. So that's just how I think about this case. And maybe I'll turn it over to Dr. Nanandala, who's going to talk about outcomes here.
All right, thanks, guys. I'm Sri Nandiala, one of the fellows at University of Utah. I'll be discussing clinical outcomes of high-grade spondylolisthesis management. I don't have any financial disclosures. So we'll start with an introduction and then move on to non-operative treatment options and think about outcomes for that. Then we'll move on to the need for reduction and discuss outcomes for reduction versus in situ fusion, and then discuss outcomes associated with circumferential fusion. There's many methods to achieve circumferential fusion, so we'll discuss in particular outcomes associated with transsacral or transdiscal fixation, and then we'll move on to pelvic fixation outcomes. High-grade spondylolisthesis is diagnosed in about 11% of adults with spondylolisthesis with non-specific back pain. Again, we all kind of mentioned the Tim Resco paper, the spine study group paper looking at balance, whether it's unbalanced high-grade spondy or balanced high-grade spondy. And it's important to recognize that because categorizing it in such a way provides a nuanced algorithm that enables patient-specific treatment instead of a one-technique-fits-all approach. It's also important to note that the current literature in high-grade spondy has a mixed bag of patient populations. There are many systematic reviews that have included low-grade slips, which clouds the high-grade spondy picture. Before we kind of get into the details of outcomes data, I wanted to start off with a polling question. In the setting of high-grade spondy, what percentage of slip reduction do you believe is associated with improvement in quality of life outcome scores? Or do you think that slip angle is more important? So we'll get to that at the end. In terms of background, treatment of high-grade spondy has evolved significantly since in the last 30 years. Before the use of segmental fixation, it was very much a posterolateral fusion technique without the use of anterior column support or thinking about reduction or pelvic fixation. Now we kind of think about everything and tailor our surgical treatment to the patient based on what we think is the best in terms of achieving a stable construct and fusion. We'll first start off with talking about non-operative treatment options. As with a lot of things in spine surgery, the long-term national data history comes from the University of Iowa, and they've looked at 32 patients who they treated with high-grade spondylolisthesis. 11 patients underwent non-operative treatment, and at 18-year follow-up, 36% were asymptomatic. 21 of those patients were treated with posterior in situ fusion, and about half were asymptomatic. The authors kind of concluded that there's no evidence in literature for prophylactic fusion for asymptomatic high-grade spondylolisthesis. It's difficult to tease out what the preoperative balance was for these patients and what exactly what patient cohort was, but it's nice to see such a long-term follow-up data on non-operative treatment. When we look at non-operative treatment, there's also a study looking at the type of physical therapy protocols. This was a study that looked at early physical therapy that worked on deep core exercises and co-activation of the lumbar paraspinals. They had a 30-month follow-up that demonstrated a significant reduction in pain and intensity. There are many limitations with this study. There was limitations in reproducibility. And again, we don't know what the different patient population was, and it's difficult to apply some of these techniques. When we look at kind of all comers in terms of non-operative treatment options for high-grade spondy, the Rush group demonstrated that less than 10% of non-surgically treated patients demonstrated significant relief. So we know that non-operative treatment is less responsive, or high-grade spondy is less responsive to non-operative treatment than low-grade spondy. Albeit it's reasonable to attempt physical therapy and activity modification. We know that based on the Iowa study, about a third of patients remain relatively asymptomatic, and it's important to treat our patients based on their symptoms. Before we kind of get into the reduction outcomes and techniques, I want to start discuss a polling question in terms of whether or not folks like to do an open reduction versus doing an indirect reduction. How do you make that decision? Once again, I'd like to mention the RESCO study looking at high-grade spondylolisthesis based on pelvic balance, spinal pelvic balance. Not all high-grade spondies are created equal, and that's really the important takeaway point. Determination of spinal pelvic balance may indicate need for reduction. Once again, the treatment options must be tailored to the patient. If we look at pros and cons for reduction, some of the pros for reduction, proponents argue that you have a better fusion rate, improved spinal pelvic balance, improved postoperative outcomes. However, some of the negatives associated with reduction, like Dr. Spiker has mentioned, there is the risk for screw pullout or nerve palsy. Although most of the time the nerve palsy tends to be transient, it is an issue to think about when considering a reduction. The other thing to think about that some of these papers did not consider is the use of partial reduction. How much reduction is really necessary? And that's difficult to kind of think about. Some folks anecdotally say that 50% reduction is enough. If you reduce a high-grade spondy to a grade 2, that may be enough, but it's also difficult to provide high-grade evidence for that. When we look at restoration of normal pelvic balance after surgical reduction in high-grade spondylolisthesis, it is effective in maintaining and restoring normal pelvic balance postoperatively, and it is associated with quality of life outcomes. This study looked at restoring pelvic balance, and 55% went from unbalanced to balanced, which is pretty significant that half of them were able to be reduced. Surgical outcomes with anatomic reduction. This paper looked at kind of the pseudoarthrosis rate or the complication rate associated with this. This was a very nice paper because it kind of broke down which patient cohort had pseudoarthrosis. And basically, patients who had severe slips, older patients, or those that required a pretty significant decompression, like an L5 corpectomy, had a greater pseudoarthrosis rate. And that makes sense, I would think. Complete reduction was associated with a lower likelihood of pseudoarthrosis and greater lumbar lordosis correction. And once again, the risk for neurological injury was associated with greater attempts at decompression. Functional outcomes were correlated with correction of the lumbosacral kyphosis. This was a meta-analysis that looked at kind of whether or not a reduction is necessary versus in situ fusion. There was really no difference in patient satisfaction or outcomes in this particular meta-analysis. However, reduction led to higher fusion rates and improved pelvic parameters. When we switch topics and talk about outcomes associated with in situ fusion can be a good option for patients with balanced high-grade spondylolisthesis. The Swedish papers that looked at this, they looked at quality of life outcomes associated with in situ fusion for high-grade spondy. These papers talk about good outcomes, but they did not mention preoperative sagittal imbalance. 35 patients who underwent in situ fusion with a mean 29-year follow-up. Interestingly, these patients were treated in a spica cast for 3 months and then a TLSO brace for 3 months. They all had good functional scores postoperatively. Once again, the patients, they were not categorized into preoperative balanced or unbalanced. and postoperative bracing protocol may not be completely applicable for every patient population. When we talk about in situ fusion, there might be some residual trunk deformity. This paper looked at kind of discordance between the surgeon perceived trunk deformity versus the patient. It's also important to consider that patient's perceived cosmesis does not correlate with functional scores. So even if a patient thinks that they feel out of structure, they may have poor functional scores, even though you have a good solid fusion. Circumferential in situ fusion is recommended if you are attempting in situ fusion because it is associated with excellent fusion rates. There's many studies that have looked at circumferential fusion. Nearly all of them are demonstrating 100% fusion rates. Therefore, anterior column support is recommended when trying to achieve fusion in an in situ situation. As mentioned, there's many methods to achieving anterior column support, whether that's inner body techniques, transsacral support, transdiscal screws, and I'll touch on the transsacral screws. The transsacral screws allow for anterior column fixation in a challenging fusion environment. We know that the L5S1 fusion bed is a high shear environment, especially in the setting of small dysplastic L5 transverse processes. There may not be enough bone mass to provide for a good fusion bed, especially if you do an L5S1 decompression. In terms of the technique, you typically place these screws across the S1 pedicle through the disc space into the L5 body. And you typically do this after potentially doing a open decompression. This was a technique paper, and they looked at 3 patients, and they all had satisfactory outcomes. If we look at meta-analysis on this, there's many methods for achieving transsacral fixation. Pretty much all patients achieved fusion, and all patients had improvements in pain and function. If we look at long-term outcomes and fusion rates for transdiscal fixation, this was a more recent study that looked at navigated transsacral fixation, which is very applicable to many of our practices. And they had very good improvement in functional scores and excellent fusion rates. If we'll talk about using a more kind of historic or contemporary transsacral fixation, the use of fibular grafts has been described in the past. It can be utilized for partial reduction, although you can also use screws. This was a paper by Lenke that looked at the use of fibular strut grafts, and they've reported excellent fusion rates and no loss of correction with no significant improvement in their, significant deterioration of their slip angle with good functional scores. Dr. Sasso published an excellent book chapter looking at dowel fibular strut grafting. They had 100% fusion rate across their study, but they also compared it to others, pretty much improved slip angles with no deterioration in long-term follow-up. In terms of the downsides of utilizing reduction techniques, if we look at the SRS data, there's about 11% new neurological deficit rate. That's really for all comers in terms of high-grade spondylolisthesis. The neurological deficit rate is mainly associated with reduction and osteotomies. Well, what about the outcomes associated with pelvic fixation? When should you consider pelvic fixation? If we look at 5-year data, iliac fixation was associated with lower outcomes associated with poor sacral bone quality and high cantilever loads. It mitigates the risk for loss of sacral fixation, and it can decrease the shear forces across that L5S1 junction. This was a paper by Dr. Ruse and Dr. Lenke's group that looked at what is the optimal pelvic fixation. They've concluded that 60 millimeter screws, greater than 60 millimeter screws bilaterally in addition to bicortical sacral fixation was the best form of pelvic fixation with anterior column support. In terms of take-home point for outcomes, we have to consider that not all high-grade spondylolisthesis are created equal. We need to consider their preoperative spinal pelvic balance and tailor the surgical technique. When we're considering reduction, we need to, once again, consider how much reduction we need and the type of shear forces that we have, and consider extending the fusion to L4 or extending the fusion to the pelvis. We need to be mindful of the risk for neurological deficits with an L5 nerve root palsy, and consider doing open decompression, completely skeletonizing the L5 nerve root, or utilizing partial reduction techniques. So with that, I will turn it over to Dr. Spina for a case.
Thanks, Sri. Thanks for that talk. Just wanted to highlight a couple things for you. I think the 4-point pelvic fixation is a really important piece, especially with high shear stress across the L5-S1 disc space in people with high pelvic incidence. I think there's been several papers that, including Dr. Ru's paper, that show there's lower rates of failure with circumferential fusion and 4 points of pelvic fixation. So in these patients with high-grade isthmic spondies, especially as they get older with poor sacral bone quality, I am quick to go to the pelvis, and often will augment my S1 screws to go to the pelvis. The other thing is, I think there is pretty good literature to support doing circumferential fusion, especially with the small TPs. So I will try to get an interbody in whenever possible. And if I can't, put something across the disc space, such as transdiscal screws. I've moved away from doing Bowman's with an ACL reamer and tend to just put transdiscal screws and put some bone graft in the disc space to aid with fusion. I also think that in these cases with high-grade isthmics, the L5 pedicles are often small. It makes placement of pedicle screws in that L5 area more difficult. I'm not a huge user of navigation, but I think navigation and potentially even robotic surgery is good in this area, especially for placement of the L5 screws, because you sometimes only have 1 or 2 chances at cannulating a very small 5 pedicle. So we'll just use the last couple of minutes to end with this case. So this is a 39-year-old female. She was referred down to us from up in Montana. She had cervical myelopathy that was taken care of up there, and then was involved in a motor vehicle accident with a T5-6 injury, requiring revision and non-union surgery up in the upper thoracic spine. She then came in with increasing back pain, right greater than left L5 paresthesias, as well as weak EHL. Her incidence preoperatively was 65 degrees. She had a relatively high pelvic tilt at 30, lumbar lordosis of 55, and lower lumbar lordosis of 26 with a 7-degree SVA. Shri, maybe you can go to the next slide. So, looking at her films, she has a very grade 2 to grade 3 isthmic spondy that's pretty burnt out. You can clearly see the defect. You can clearly see the severe foraminal stenosis on the bottom left CT cut. Her L5 pedicles were relatively good size, as you can see from the center portion, and she had very sclerotic anterior cortex of her sacrum from this long-standing isthmic spondylolisthesis. So in treating this, I thought she had good enough bone quality to try to get away with doing an L5-S1 standalone monosegmental fixation, getting an expandable cage in from entering the disc bilaterally and then putting a unilateral cage in. You can see we increased her lower lumbar lordosis to 42 degrees, definitely helped her pelvic tilt, reducing it from 30 to 19, and these are immediately post-op, so she may improve slightly more moving forward. The technique we used, which is commonly, what we do use, is I use reduction tulips on my L5 screws. I tend to put a lamina spreader between the L4 spinous process and the sacrum to gain some distraction. I then distract between the screws, and I fix my rod into S1 higher up in the reduction tulip. I'll then distract between the lamina spreader as well as between the screw heads to try to gain some distraction. In this case, I actually used two head-to-head distractors to gain distraction, removed one, and then reduced it to a rod on the contralateral side. And then if it doesn't move, I tend to get in the disc space like we talked about earlier and loosen things up. But we had a pretty good outcome here with monosegmental fixation, did not go to L4 and did not put pelvic fixation in, largely because of that sclerotic end plate at S1, giving us really, really good purchase on our S1 screws. So that kind of brings us to the end of the talk. I think we've highlighted some of the controversies surrounding high-grade isthmic spondylolisthesis, in addition to highlighting the complications that are associated with reduction versus not reducing, and really the pelvic considerations in terms of addressing sort of global balance at a monosegmental instrumentation for these high-grade isthmic spondies. I'd like to thank everybody for attending and joining us for this webinar. I'd like to thank Dr. Spiker, Dr. Saul, and Dr. Nanandala for helping us put this together. I encourage everybody to attend the next one, and thank you guys for your participation. If anyone has any questions, we'll stay on for a minute or two, and please type them into the Q&A box. Otherwise, have a wonderful night, and thanks for joining us.